Kurt, do you? Thank you.
I'm calling the meeting to order.
Thank you.
And we have the members present, Linda, Sam.
Yes, we've got
Christine.
a quorum. Christine.
And are there any public comments?
First, we need to go through corrections and approval of previous minutes from January.
Does anyone wish to move approval of the previous minutes?
So moved.
Second.
We'll proceed then.
Okay. You want to vote?
We had a vote, I think.
Oh, Greg's here. Okay, great.
Sorry, who seconded it? I did.
And a vote to approve the minutes, previous minutes?
Aye.
Aye. Okay. And Greg, we've got you.
Hi there. I'm trying to get connected here. Sorry I'm late.
Okay, Greg can proceed now.
Great. Dr. Kurt got us rolling. The meeting has started and we are on to public comment.
Great. Thank you. I'm still trying to hook up my headphones, but I will do that. If we see any public comment, you may have to notify me if there's anyone else in the room or online.
All right. Is anybody in the room here to make a public comment? No one in the room, Greg? No one online?
Okay, we're going to take it back. Thank you. Get back to my notes.
The next thing on the agenda.
Corrections. Right. Oh, we're already past that. You already did that. Sorry. Still catching up. Alternate position and chair. I'm going to let Jordana take that away.
Okay, great. So before we get into elections, I just wanted to take a minute to recognize our new Board of Health alternate member, Michelle Michonne. Michelle, do you want to take a minute and introduce yourself?
Sure. Michelle Michonne. I've been in the Valley for about 14 years and been a clinical social worker for 25. Worked for the hospital for about 10 and in private practice now. And I just wanted to give back in some way. And this was brought to my attention. And here we are.
We're really excited to have her join, as we haven't had someone with mental health experience as a clinician on the board in a little bit since Christina King resigned. So Barry has since resigned her position as alternate, and Michelle will be serving in that role. So welcome.
Thank you so much.
Ted, would it be helpful just to have everyone on the board?
Great. Thank you for doing that.
Yeah. We can.
Of course, if you think.
Okay. We can do, we've got a new Board of County Commissioner, Ted Mahone. Also just observing the Board of Health right now.
Hi, everyone. Thank you. Yes, Ted Mann, appointed recently to fill Kelly's vacated seat. And Jordana and I had been speaking about the upcoming discussions on renewal of the Healthy Community Fund. And that was something that I was interested in. I talked to Greg about this a month ago at a retreat. And I had prior experience with a ballot initiative to renew the city open space and trails half-cent tax. And that was in 2022. So just a little bit of experience organizing a committee in a local campaign to try to push that ballot initiative through, which succeeded very well. So we're still, as a BOCC, discussing options and how we want to move forward. But I mean, I can help with questions, but I just wanted to volunteer my, services or willingness to help with that campaign when that comes up. I'm not sure how far along this board is on those discussions.
We'll start at the end of the day today, at our end of the meeting today. So we might call you back up for some of that experience.
If I could,
yeah, I mean, if I can offer any now, or maybe it's in future discussions, but I'm here.
Great, thank you.
Great. Ted, thanks for coming in today. Really appreciate it. And I think having Ted step on board with this to help, I'm going to be working with him on it as well. I think we're going to have an excellent campaign ahead of us, but we're going to be relying on help from board members when the time comes. And I'm hoping everyone's as enthusiastic as we are, but I have to say my enthusiasm went up dramatically when Ted expressed his interest in doing this.
Thanks, Greg.
Thanks.
We've got a couple minutes here, so I wonder if, just for the benefit of Michelle and Ted, if board members would be willing to just give a quick introduction.
And I know some are good friends, some are acquaintances. I know everyone to some degree. Michelle, just kind of remember reviewing a little bit about you. Welcome to this board. But without going into too in depth, because I do feel like there's a lot of familiarity here. Linda, we never met personally, but I know your background. So, maybe we don't need to, but
and I don't know if Michelle.
Tom as well.
I know
Not
a few,
everyone either.
but not many, so it would be good to just do a little review.
That's great. Tom, would you start?
Yes, I'm Tom Kurt. I'd like to start as an original member of the board with Marky Butler, in whose remembrance I'd like to say something on her behalf. As a wonderful leader. Not only was she the mayor of Snowmass, but as you know, she first chaired this board, and then she was on the CMC of Aspen board. And I'd like to say I admire and respect her on that behalf. In addition, I'd like to point out we have a senior center, which is part of the Healthy Community Fund. And I've been involved with that for years. It's adjacent to the hospital, and we put on things there, like in May, I'm going to be talking about polypharmacy and de-prescribing. In other words, as seniors get older, they need to cut down on the doses and the number of their drugs.
Thank you.
And our early board also got us through COVID, and those were memorable days.
I can only imagine.
Susan?
I'm Susan Marolt, and I am on the Snowmass Village Town Council currently, and prior to that on the school board for many years, and I've been on the Board of Health for about 4 years, I guess. Yeah.
Sam Rose, City of Aspen, City Council representative, and also volunteer firefighter and civic member and former Pitkin County Public Health employee during COVID.
Mm-hmm.
Christine Benedetti, Aspen City Council. I'm the alternate for our representation here.
You know me.
Do you know Michelle?
Oh, no. Hi, Michelle.
Hi, Liz.
Linda
Linda.
Vieira. I'm an advanced nurse practitioner. I just switched from private practice to community health services full-time. I've been working at community health for 47 years. And a long time, I'm very old. And I've been on the Board of Health, I'm not even sure, 7 years? 7? About 7. I came on during COVID. It was quite an experience. Yes.
Thank you.
And I know Michelle and Ted. Just of note, I'm not a board member. I'm a consultant to the board and work closely with Jordana as the county medical officer. And as you know, emergency room doctor here, and I've been our medical officer for almost 15 years. So pre-COVID, through COVID, after, and just working closely with an amazing team. So it's been great.
All right. Well, thanks, everybody. Greg, I'll turn it back to you if you want to. Oh, no, this is still my section. Yep, thanks so much, Ted. Man, sorry, I mispronounced your last name. I'm sure that never happens. The next thing on our agenda, has Krista joined at all? No, okay. Krista is also.
Chris is our vice chair. And so we're flying without the two pilots in the pilot seat, and I apologize for that today. I'm a DIA, but I'm present, and I'm trying to follow. It's a little quiet, so sometimes if you have to get a mic near you to speak, that'd be great. So we're still on chair, co-chair. Jordana.
Thanks, Greg. The next thing we have to do is annually we elect a chair of the Board of Health and a co-chair of the Board of Health who assumes those responsibilities if the chair isn't able to be present, lead the meetings, help develop the agendas. It is time for us to go through that process. So how we do this is we have anyone who would be interested in the chair position be nominated, and we need a nomination and a second for any of those interested in the position, and then we'll vote, and then we'll go on to the co-chair, vice chair position. And I know there's been some interest of our current folks to continue on the role, so I will open it up for those who would be interested to serve in as the chair of the Board of Health for this next year.
I'll raise my hand since I've already told Jordana that I'd be willing to keep going if you'll have me. And this isn't representative of my typical chairing. I can say that. Being so remote.
For stability,
Yeah.
I nominate our continuing Greg as chair, Christine as sub-chair.
Second.
Yeah, I second.
Okay. Let's go ahead and focus on the chair and just see if I'll pause and just ask if there's any other nominations.
Just go through the whole list of
And criticism is welcome also, by the way.
Alternates can't be.
Alternates
they
can't
know.
be a chair or vice chair.
So are there any members that are not here besides Krista?
The only other folks who are full members who are not present today, Liz Stark is absent, but she is
Let's
also.
nominate her.
We could nominate Liz.
She'd be great.
She would be great.
She would.
Our ghost is here.
If I could nominate, I'd nominate.
All right, so that is for the position of chair. We have one nomination for Greg Poshman to continue in that role. All in favor?
Aye.
Any opposed?
Aye, I'll do it too. Thank you all. I appreciate your trust and your confidence, and I'll try to live up to it. You've made it so easy for me that it would be very easy to become even more of a slacker. So if I'm open to hearing suggestions, and I want to make sure people know they can reach out to me. And I do want to say I am going to do my best to get Ted Mann on as our alternate next year. As we know, Patty will be leaving at the end of her term, and we're going to need to appoint a new vice chair, a new alternate from Pitkin County. And that's part of my Machiavellian strategy to get Ted engaged now. Thanks.
All right, and we've had a nomination for Krista to continue to serve as the vice chair from Dr. Kurt. Do we have a second for that?
I'll second.
Okay. And any other nominations for vice chair? Okay.
And Jordan, I can share that Krista has expressed to me that she's happy to do it. So I think we're okay there too.
Great, thanks for that, Greg. Okay, with that knowledge, we'll call it for all those in favor of Krista Giesel serving as our vice chair.
Aye.
Okay, all opposed? And that one was unanimous.
Thank you. You're really good at this.
All right, great. That is it for the alternates. Oh, just before we leave this agenda item, I'd just like to remind folks who have been on the board that you'll see in your email there is a link to sign a thank you card for Barry. Thank you to all those who have signed. If you haven't yet, that'll get delivered to her tomorrow. So just take some time to go in and let her know how much we appreciated her serving in that role.
Thank you for the reminder on that Jordana. I'm just reminded of when Barry stepped in during COVID and was so proactive in helping us through her connections in Los Angeles when we were trying to find tests and we were trying to understand what was going on. And Barry was part of a small team, including Krista and you and several others who really stepped in and made it work. So I wrote her a little note to that effect, and I just really appreciate her.
Great, thanks, Greg. All right. Greg, with that, you can move us
Okay.
on to the next agenda item.
Okay, is Brian in the house? Or we're the on-site wastewater treatment systems regulation approval.
Yes.
Take it away, Brian. Welcome. Sorry, I'm not there to see the front of your face. I'm looking at the back of your head, but that's okay.
Anyways, there was a noticing error prior to the previous
Hey,
meeting.
pull your microphone closer if you don't mind. Make sure the red light's on.
The red light on?
Can't tell.
If you put your hand around it.
Okay, it is on.
Nancy, if you can go to the next slide.
Okay. So there was a required 30-day previous to the meeting newspaper noticing that did not recur prior to the previous meeting. So we're going to do a redo. We did the noticing as required now. So it's the same proposal as previous, that the state rewrote their regulations last summer, and we have 1 year to rewrite our regulations to meet those. So we've sent that over to the state and got those approved for meeting their criteria, and we just need to have them approved by the board in order to get them to be in effect 45 days after. And OWTS is the on-site wastewater treatment systems for all of the houses outside of city limits that are served by sewer systems. So they each have their own disposal system on their own, or treatment system on their property. And that's what this is regarding.
So this was presented in more detail back in January, and we just need to bring it forward for another vote since we've now accomplished all of the proper noticing requirements. Any questions about the rule change? Okay.
Yeah, most of these rule changes were specific to what the state changed. We haven't really have anything much above and beyond what we previously had. So, yeah.
Okay, with that, Greg, we'll just need someone to call a motion.
Right, looking for a motion for this. I'm sorry, I'm having trouble hearing, but I can hear you, Jordana, quite well. So looking for a motion in a second. You may have to alert me if I can't see. Dr. Kurt?
I'll second it.
I'm not sure. Was that Linda?
Yes.
Great, thank you. All in favor?
Aye.
All right, thank you.
Thank you very much.
Thanks, Brian.
And now, Greg, you will see a DocuSign come your way to just officially sign off as the Board of Health Chair. We'll both sign off on this, and it will go into effect, Brian, 45?
Yeah, 45 days after we are signed today.
45 days after it gets signed, it will go into effect. All
Right, thank you. And if that can come to me today, so much the better. I'm getting on an airplane at 5:30 and I'll be gone for 2 weeks.
Nancy has sent, it's ready. She will send it right away.
Excellent, thank you. Okay, so if we can keep moving, Carly's up for the epidemiology update.
Carly's up, but we are so ahead of schedule
Fine.
that.
She's online.
Oh, she's online. She's here.
I am.
Carly,
I'm
fantastic.
listening in. I'm looking. I am looking for parking right now. If you give me 2 minutes, I can get there in person. But
you know, we can talk about something else for 2 minutes, Carly.
Are you sure? I just got out of the car. I can truly be there in like 2 minutes.
Okay,
so
no worries.
I'll be right
No
there.
worries.
Great. Well, we'll let Carly come in here today. In addition, you'll notice that our epidemiology update is a little bit shorter than usual because we will have some guests from the state coming in to talk about wastewater. That's been a tool that we've been using just since the middle of COVID, where we can look at wastewater rates of diseases that are popping up in communities. So we'll get some more information about the state program. We can ask lots of questions, see what they're monitoring for, and get to understand that program and where it's headed a little bit better.
Jordana, while you're discussing that and having them come in, I think it's great. During COVID, I remember early on in COVID, Dr. Kurt was bringing up this new idea that we could be looking at wastewater. I think he was the first one who introduced me to the thought back then. And so I just want to say kudos for being so far out in front, because I look at how it's ubiquitous now and we depend upon it.
Absolutely.
Well, the Aspen wastewater plant, I inspected years ago in the beginning of COVID because, you know, that's where the sampling goes for wastewater for COVID as well as flu and other viruses. And that's so important because in the beginning, everyone was being tested at a public testing spot. Now you can buy all your testing kits, so you don't know really from testing. So the wastewater testing is a critical area. And I visited the wastewater plant, and I assure you, it does not have the odor that you might suspect would be there because they biologically reprocess. And it was a very interesting visit.
All right. Krista needs the direct link and then she'll be on today. Let me just take 1 minute to send that. Greg, you know, the other option, Dr. Kurt, I know you had a couple things during round robin to discuss.
We can go there. Yeah. Let's do that. If Carly's not in the room yet, if we could, Dr. Kurt, we can go to round robin, and generally it's anybody has something they want to bring up for us.
Well, just yesterday afternoon, I got an email from Joanne Gould, who's at CDPHE, and she's in charge of trainings. And what she had forwarded to me, because I'm one of the 6 people in the state of Colorado who's in a more rural location, serving on this kind of training obligation. And Pitkin County has opted every year to do the training as a group, which is a wonderful group experience because we can interact and have conversations. Otherwise, you need to sign up for these trainings on your own every 3 months. And that is a kind of a tedious process. So I reassured her that we would probably be doing the group training again this year. And I forwarded that to Jordana, who can indeed forward that information to you because I just received it yesterday afternoon.
Great. And thank you for sharing that with us. And it sounds like if we can continue the way we did the last year, that would be great.
All right, Greg, and we have got Carly in the room.
I see. Welcome, Carly. Thanks for being there. Sorry, I'm not. Please go ahead.
Absolutely. Jumping right into it, respiratory illness season, we are on the tail end of this, fortunately, right now. Do want to highlight that flu is really our big bad this season. I know that many of us had talked about this 3 months ago, what we were seeing locally, what we were seeing throughout the state. But now that we're kind of on this tail end of the season, we are able to kind of get all of this collective data regarding this. So just a quick recap. Flu A was the one that was really driving a lot of hospitalizations, not only locally, but also nationally. That is because at the very end of this Southern Hemisphere flu season last year, the flu A virus mutated into what's called the subclade K kind of variant, and that just didn't match up very well with a lot of our flu shots. And so this is why we saw this really large uptick in flu activity earlier in the season. We locally saw quite a bit of increase in hospitalizations and activity earlier in the season, and that's due to that flu A. But now that we have started this postmortem on the season, we did get data that the flu vaccine was actually roughly 30% effective at preventing hospitalizations or reducing hospitalizations across the country, which is still pretty significant. Flu season, flu vaccines are not as effective necessarily as our mRNA vaccines. It's 30%, falls well within the range of sort of what is standard. Ooh, how many more? And then for RSV, we did get a late season boost. So this last couple of months, we've actually seen a lot of RSV circulating locally. Excuse me. This has led to hospitalizations across the country. It's not uncommon that this happens later in the season, but it is sort of unique. And so we saw sort of this kind of early flu, late RSV, and that might be falling in line with what might be the new norm, where we have these three viruses circulating and sort of competing for dominance at any given part throughout the season. COVID-19, it was a quiet season. This is a little bit more abnormal. It was the quietest season that we've seen it since the actual pandemic. And so this could be due to many, many things. No one quite knows why. We had a pretty big increase in late fall activity last October, last August. And so that might be why we might have had strong community immunity. The new variants might not have mutated as much. And so all in all, fairly quiet COVID-19 season. It is still around, it is still present, but not leading to a vast majority of hospitalizations that we saw due to respiratory illness. Incoming, we do have the cicada variant, if anyone's been paying attention to the headlines. I know Dr. Kurt was kind enough to forward on some articles about this. So this is the variant BA3.2. If anyone's been paying attention to all the BAs, all the JANs, all the QX and NEXs and all the rest, that this is a distinct difference than what has been the dominant variant for the past, honestly, 2 years. So for the past 2 years, we've seen lineages coming from JN.1, and that this BA3.2 is significantly different than that. What that could mean for us is that we could see an increase in COVID activity, especially going into the later summer, which is when we started to see that increase in activity across the country at this point. We typically see 2 COVID waves now, typically in the late summer, and then over the holiday season. If I had a crystal ball, if I could throw my hand at trying to predict this, my guess is due to this mutation, we are going to see an increase in COVID activity going into the summer. Not a guarantee, but always possibility. Good news about this is that this is not out of the ordinary for COVID-19 at this point. There's no indication to show that this is causing more severe illness. It is ultimately that this is what COVID is very good at, is finding where our immunity is working and finding some way to subvert that. So still around, still present, keep an eye on it. The big vaccine updates for all of these is that recently the CDC has delayed releasing the COVID-19 efficacy and safety data for this past season. That is likely due to politics, not necessarily due to anything different around the COVID-19 vaccine itself. There is still no confirmed CDC director who is typically the person who released that data, and so it's probably wrapped up in all of that. Excuse me. Also from the headlines, a federal judge has placed a hold on all ACIP meeting findings and decisions since last June. And do just want to highlight that because of the way that the CDPHE has moved away from aligning our statewide vaccination recommendations with the ACIP, instead we're looking at the American Academy of Pediatrics as well as other third-party medical professionals. This doesn't impact what's happening locally or in the state, but do just want to highlight that that is an ongoing development and may impact things into the future. And that the ACIP has worked towards updating their charter. This is likely wrapped up in this judge decision. It's ongoing. Lots of things are shifting. We are keeping an eye on it. And that ultimately with all of those changes, it's very difficult to predict what this next 2026 to 2027 vaccination season is going to look like. But we are keeping track. Unfortunately, Colorado has been really proactive in trying to meet these ever-changing demographics and landscapes to make sure that if there are vaccines available, that Coloradans have access to it. So, respiratory illness.
I'd like to comment because the April 14th Journal of the American Medical Association has an article on that exact topic, and I just gave that to Jordana, which she will pass over because there's some color portions of it, which my copier or scanner would not really provide. So it's about subclade K, where a specific vaccine will not really be prepared for that until the early fall season. And I would suggest that people get an early vaccination for that. The existing vaccinations will provide you with some resistance, but you also need to remember that there is Tamiflu available as a medication if you think that you have the flu. And just when I was at City Market Pharmacy a few days ago, there's now a test kit that tests in the same kit for Tamiflu, RSV, and COVID in the same home test kit. So if you think you have one of the three, get one of those because they cost about $10, and that's a quick way not just to find out for yourself, but to reassure the other members of your family, as I've had to a few times, that I don't have any of those if I have a little seasonal cough because I have allergies. So remember subclade cave. There is a remedy called Tamiflu, and to watch to see what's going to happen for this fall.
And just to add to that, Tamiflu is only effective for the flu, and we prescribe it for flu positive when you're flu positive, not if you think you have it, but you have to be diagnosed with it. And it's not effective for, as you said, COVID or RSV.
Yeah.
It's also not a treatment. It's just something that can help prevent hospitalizations.
Yes.
So when you're saying that it'll be available early fall, does that mean in October, do you think, or September?
The
possibly?
vaccine manufacturers, like Pfizer, et cetera, will be announcing, and they usually say announce in August, and it's available usually in September.
Yeah, okay. Thank you.
And it will depend some, especially with the COVID, it will depend on some of the federal guideline,
Right.
everything, so. Nailing down a definitive date. is
TBD.
tricky. Exactly. We're hoping for early fall, hoping for October, September sometime.
Remember, there are 4 risk factors: age, obesity, diabetes 2, and hypertension with the meds.
Is that everything, Carly?
One more fun one.
Okay.
Next slide. All right. Again, the fun one. So measles is ongoing. Like we've mentioned about in the last few meetings here, it is likely, in all honesty, that the United States is going to lose our eradication status the next time the World Health Organization needs to determine that. That's not shocking. We knew about that like 6 months ago. But it has been 1 full year, ultimately in April, of ongoing measles spread throughout the country. And so in 2026, we have already had 1,700, I think they just updated this to roughly 1,800 cases in 2026 so far. This is looking back at this ongoing outbreak throughout the United States of 2,287 cases total in 2025. Just want to highlight again, no, I'm preaching to the choir here, but just how effective those MMR vaccines are. So 92% of cases have presented in unvaccinated individuals. 4% have only received 1 MMR dose, and of those fully vaccinated individuals, typically there are secondary considerations or high levels of high-risk exposure, i.e. family members or immunocompromised or anything like that. So those numbers almost perfectly match up with our efficacy data for the MMR vaccine. So just, again, those work. Those are great. At this point, again, Pitkin County is sitting pretty at about a 96% vaccination rate with MMR going into kindergarten. That's huge. We are a highly vaccinated community, but this does not make us immune. Just want to call out that there was a recent, they're about to close it, but there was a recent outbreak on the Front Range associated with Broomfield school districts, and that school also has an incredibly high vaccination rate of 97%. And so when we're looking at these outbreak risks, just because we are highly vaccinated as a community does not mean that that risk is shared equally across our community. And so typically where we see those highest risks are in sort of associated pockets, meaning that just because as a county we see these high vaccination rates doesn't mean that there are these pockets of risks that could make us kind of vulnerable to those outbreak settings. So we are always keeping an eye on this, always keeping track of this. Fortunately, there have been no additional cases due to this outbreak in about the last 10 days. And so it's something that we're watching, something that we're tracking, but that there continues to be very little risk to Pitkin County, especially with our off season coming a little bit earlier this year. And so we have no known exposures, no known cases locally, but we are consistently trying to make sure that we're keeping an eye on this, tracking this, watching what's happening in our state, And also just want to call out what's going on in Utah right now, since it is bordering. Utah is currently the epicenter of increasing cases throughout the United States right now. And there are a few things that are a little bit concerning about what's going on in Utah specifically. And that is because there are many, many cases coming forward at this point that are non-equivalent to known cases. This is a strong indication that there is community spread going on throughout Utah. And that there are many, many unknown cases, that this is functionally uncontrolled, and that their wastewater is showing similar things, where they're seeing a lot of cases and a lot of wastewater detections throughout the state. So this is no longer associated with pockets of exposure, but it looks like there may be an increased risk in Utah, and that very few signs of slowing down. Again, hopefully it doesn't impact us. We don't have any direct lines to Utah, but of course we share that border, and we are just keeping track of that as much as we can. So again, limited risk to Pitkin County, but something that we're always keeping an eye on. Yeah.
Charlie, awesome.
Okay.
Dr. Giesel is now on now. Does she wish to comment?
Hello, I have no comment.
Hey, Kristen. Welcome.
Thank you. Sorry.
And thanks, Carly. Thanks for that. Are we ready for our next guest now? Is Allison here?
Yeah.
Or online, I assume?
I'm here. I'm online.
Great. Allison, welcome. Thanks for joining the Pitkin County Board of Health today. And you're up and ready to go when you are. And we see your slides.
Wonderful. Thank you. And thank you for having me. Just quick sound check. Can you all hear me okay in the room?
We can.
Okay, wonderful. Yes, so thanks to Carly. Carly invited me to this meeting. Carly and I have worked together for the last few years. I lead our wastewater surveillance program at the state level. And of course, I think you all know that the Aspen Wastewater Utility is one of our participants in our Sentinel model. So I'm going to talk today just a brief overview of the program and some of our successes, and happy to answer any questions as well. Next slide, please. So I wanted to start with just basics. What is wastewater surveillance? Because it is a relatively new surveillance system that came about during COVID, at least in the United States. It's been around for a long time in other countries. A major advantage of this surveillance system is the ability to look at a community-wide sample. So rather than testing individual people, we're testing a community of folks, which is cost-effective, non-invasive, and helps protect the privacy of ill individuals. By analyzing what's present in wastewater, we can track disease trends across a population without relying on individuals to have access to healthcare or to seek out healthcare for testing. And so this overcomes some of the challenges of clinical case reporting, including the delay between infection and testing. So in Colorado, we feel that this surveillance system adds an important layer of insight to our disease monitoring system. So it enhances preparedness efforts and helps informs decisions. But it, of course, works best when interpreted alongside other available sources of data, including clinical and syndromic data. Next slide, please. And so there are several benefits to this system. And, we share this data publicly with Coloradans through a public dashboard so that they can assess their disease risk. An example that we've heard from community members is if they're immunocompromised, they take a look at the dashboard, they evaluate those disease trends in their area, and then decide if it's a good idea for them to travel around the state. We've also, I always use my grandma is 102 and lives in Colorado Springs, and I always look at the data before I go and visit her to make sure I'm not taking, anything. If there's the high rates of flu, I don't want to go visit her during that time to expose her to illness. We know that with some of the pathogens that we monitor, people can shed the virus into wastewater before they have symptoms, or sometimes even if they don't develop symptoms. So we can pick up infections when people are asymptomatic. When we see an increasing trend of illness in a certain area, so COVID or flu or RSV, or even a single detection of what Carly was just talking about, measles, so an emerging pathogen, we message our local public health partners and we work together to message providers in the area so that to let them know that this particular pathogen is circulating in their area, to be on the lookout for it, a reminder of symptoms, since a lot of our providers have not seen measles for quite a while or ever. And then it also helps some of our hospitals have adequate staffing, say during a respiratory virus surge, or just at least having the appropriate vaccine or therapeutics on hand. So there are limitations, as with every surveillance system. And because we're testing at the sewer shed level, or the area that is covered by that wastewater utility, we're not able to capture residences on septic systems or those who are on decentralized systems. So some hospitals, some prisons who process their own waste. We've seen sewer sheds in areas with high tourism, so Aspen too, provide less stable signals due to a high population influx and efflux. And so what we're doing with that is looking at mobility data, so cell phone data, to track those people going in and out. And we cannot track individual people, but we're able to tell if the signal that we're seeing in wastewater is likely due to high tourism, a high tourism time, or if it's likely the population that resides in the area. We know that the amount of virus shed from person to person is variable, and this is different by pathogen too. And so we can't estimate the number of cases per community alone, or per community using wastewater data alone. Next slide, please. So what does this whole process look like? We provide collection supplies to participating wastewater utilities. Our wastewater utilities are incredible to work with and provide just such an important public health service. And so they collect these samples for us in kind, and they collect a sample as it's coming into the wastewater treatment plant. So before it's been treated, we provide a courier to get that sample from the wastewater utility. And then once that sample gets to the lab techs concentrate the sample and test it to detect the amount of virus in the sample. After the virus is detected, our lab has the ability to characterize that virus. And so meaning they can determine which variant or subtype is in that sample. And so, for example, we're able to subtype flu. And so we can say, the sample's positive for flu A. Is it H1, H3, or H5? Our lab is even ability to determine the subclade of flu. And so we were able to detect subclade K, as Carly talked about, in our wastewater samples. The lab then reports the results to our data team, and it is a very large, very messy data set. And so we've got a data team that takes this data set and digests it into something that we can put on our dashboard that is more interpretable for our stakeholders, including our local public health departments, our wastewater utilities, and the public. Next slide, please. All right, and next slide. Okay, so when we first started this back in 2020, the directive from the governor was add as many wastewater utilities throughout Colorado as possible. We want to see what's happening with COVID rates across Colorado. And so we did just that. Well, there are over 250 wastewater utilities in Colorado. And we, at our height of enrollment, we had 68 participating utilities. And as we started to add new targets, we knew this model was not sustainable. So we worked with a graduate student at the School of Public Health to figure out a sentinel system that really represents Colorado's population. And so what we found, the sentinel sites here are indicated by the orange triangles. We have at least one in each of our 9 all-hazard regions, which are the different pastel colors on the map. We have a total of 21. In addition, we have 4 additional sites within the Denver metro area because they cover very large populations. We have, 3 additional sites. And then we have 4 high tourism utilities, including Aspen, because what we found is that the viral concentration signal in those high tourism utilities it was variable, and it didn't correspond very well with the sentinel site signal, which is understandable because of that population influx and efflux. Because we had developed this framework of participating wastewater utilities, we didn't want to let that go. And so all of those sites that are non-sentinel sites indicated by the little yellow circles, we transitioned them into what we call an emergency surveillance site model. These utilities do not collect samples for us on a regular basis, but they're on standby in case we have a public health emergency or we need more data around the state to help us evaluate what's happening with diseases in communities. And so we've done this with highly pathogenic avian influenza when we had several positive dairy herds in northeast Colorado a couple of years ago. And we are also currently doing this for the measles situation. So even though we reduced our participating utilities by 2/3, we're still covering about half of Colorado's population. Next slide, please. All right, so what exactly are we testing for? These are our current targets on the screen. We started with COVID, of course, back in 2020. We added flu A and B and RSV, I believe in 2023, and then enterovirus D68. And I'll talk about this a little bit more about why we chose this specific pathogen and what it is. We also monitor for Mpox clade 1 and clade 2, which thankfully we do not see a lot of in Colorado. We are monitoring for measles and have had success with that. And then West Nile virus was one of our pathogens that was in a pilot phase last year to see if we could detect it in wastewater, and we were able to. And so we are starting our season here on May 1st, and that will be added to our public dashboard. We're currently in a pilot phase to monitor Candida auris, a fungus that can spread very quickly through long-term care facilities and causes pretty serious infection, as well as antimicrobial resistant genes. And once again, we do all of this surveillance at the community level. Next slide, please. So this is a screenshot of the trends from our public dashboard, and I included the link below if you wanted to check it out and maybe even bookmark it so that you can keep track of the data. But we post trends of disease from all of our participating utilities on this dashboard. And it's once we have validated our assay and these targets have made it through the pilot period, or the assay has been validated and we've moved past the pilot period. We also include our flu subtyping data. So H1, H3, and H5, as I mentioned earlier. We do stop H1 and H3 will stop at the end of May. We will continue to monitor for H5 all throughout the year. So H1 and H3 will be added back during viral respiratory season this fall. And we also post data, COVID variant data. Next slide. So I wanted to share a couple of the success stories. Thank you for that we've seen in Colorado, and this one is about EVD 68. And so this is an enterovirus D68 that usually causes a mild respiratory illness, but it can cause more severe respiratory illness, especially in children with asthma. And this can result in a condition called acute flaccid myelitis. It's like a polio-like symptom. And so it's really concerning, especially to our partners at Children's Hospital. And so during years where we've seen an increase in the number of EVD 68 cases, we've also seen a strain on pediatric healthcare resources. And so working with our Children's Hospital partners, we were all curious whether wastewater surveillance could help us prepare for EVD 68 season. In 2022, we saw an extremely high number of cases in Colorado, and we had been collecting wastewater samples, and we had some frozen banked samples. And so we decided to look back at samples from that year during EVD 68 season to see if we could detect EVD 68 in wastewater. And we did detect it. And so you can see here that the wastewater concentration is in gray, and then our clinical signal or clinical cases is in dark blue. And if you'll look at this gray line, you can see a steady increase here before we see that increase in clinical cases. And we saw that the wastewater gave us almost a month lead time before we started seeing that increase in clinical cases. And so if this had been real time, we would have been able to message our Children's Hospital partners and say, hey, we're seeing an increasing trend in EVD 68 in wastewater. It's time to make sure that you have adequate staffing, that you all are testing for EVD 68, and looking out for AFM. Next slide, please. All right, highly pathogenic avian influenza. As I mentioned, and I'm sure you're all aware, in 2024, we started seeing herds of dairy cattle that were infected with flu A H5N1. And so over a period of 2 months in Colorado, or 4 months, sorry, we had 64 infected dairy herds. And our concern was that this flu was going to mutate and possibly cause illness, very serious illness in people. And so we were curious whether we could pick up H5 in wastewater, and sure enough, we did. So on the graph here, you can see with the red bars, we started seeing positive cattle. This is back in April of 2024. And we started testing wastewater using an H5 assay on July 11th. And we detected H5 above the limit of detection of the assay in 4 utilities, and in very low levels at 12 utilities. And so we continued to detect H5 through August 26th of 2024. And so when we had a positive detection at a wastewater utility, we would reach out to ask about positive or possible inputs. And so we found that even though our affected dairies were not directly contributing with their wastewater system to a positive sewer shed, several of them had milk or dairy processing facilities that were contributors to the sewer systems in that sewer shed. We learned that there was one incident with a milk tank on a truck that ruptured and spilled into the sewer system. And even though, and we detected H5 in that sewer system at quite a high level, even though it was not a live virus, we're still detecting it in those milk samples. We also learned about wild birds that frequented a equalization pond at a wastewater utility, which is a pond that they divert their waste to when they can't process the high volume of wastewater, and Canadian geese hung out on that equalization pond. And so we think that was the detection of H5. And finally, last slide. All right, this is it, measles. So we have had success detecting measles in wastewater before we see clinical cases. This is an example of cases from Mesa County. And so we saw measles in wastewater. We had 2 detections, a very low level detection and then a very high viral concentration signal from the beginning of August. And we called Mesa County Public Health and they said, well, that's interesting because we haven't seen clinical cases. And we said, we're pretty sure, based on this signal, that there's community transmission happening in your community. And sure enough, they identified the first case 3 days later, followed by 10 additional cases in their community. And so wastewater, even though it was a couple days notice, it was able to give them a little bit of time to prepare some communications for their local providers so they could understand that measles was circulating in their community and they needed to be on the lookout for it. And I think that's all. Last slide, please. Yeah, with that, I'm happy to take any questions and thank you so much for having me and Carly for being willing to promote wastewater surveillance and really use the data.
Thank you, Allison. That's fascinating stuff. Really appreciate it.
Thank you.
I agree. That's so interesting. Thank you.
Right. Questions from the house. Jordana, can you field them if there are any?
Yeah. Any questions, Sam?
Do you know how many people what percentage of homes don't have septic systems, especially here in Pitkin County?
So I can't speak to Pitkin County individually, but I can say that we know 20% of Coloradans are not covered by a wastewater treatment plant, so they are on septic.
And the rates we looked at with the landfill several years ago, it was about 20% of the county isn't on either a wastewater system or like we have community systems as well. Aspen Village and Lazy Glen both have their own individual systems, and then everything else would be septic.
So conversely, 80%.
80% of the county's covered, yeah.
Okay.
And
Good chunk.
we also have the 2 wastewater systems in Pitkin County that Allison works with. Is Aspen is the one that's currently being utilized. We also have the Snowmass wastewater district as well that is on the emergency list. So it is split that way too.
Right. And then there's Redstone has its own wastewater system as well.
On septic. Yeah.
And then the rest of that is on septic.
Yeah. Interesting. Okay. Thank you.
Any other questions? Okay.
Thank you, Allison.
Thanks, Allison.
Thank you. Thanks, Allison.
Thank you.
Information.
Okay. Are we ready to move on, Jordana?
Yes, please.
Okay. The WIC program update.
Yes. Is Keith online yet? Oh, yes.
Is that Ariel?
Yes. Can you hear me online? Okay.
I can't hear you online. I don't know if it's a matter of the microphone or maybe it's just all going through Jordana's laptop for me, but it's really hard to hear for the online folks.
Is
Try
this better?
speaking that's much better. Thank you.
Okay, the microphone was off.
Oh, there you go.
That explains.
Before you jump in, I just want to take a minute to introduce Heath Harmon, who is online to answer questions and give some more commentary during this brief presentation. He is the public health director over in Eagle County, who is who we partner to provide WIC services to Pitkin County residents. So welcome, Heath.
Thank you for that, Jordana. Thank you.
Thanks for being here. Okay.
All right. So I'm going to talk a little bit about WIC in general before we move on to the specifics of our partnerships. But WIC is a pretty well-known program. It stands for Women, Infants, and Children. And this is an income qualifying program. So there's a population eligible, including pregnant women, mothers of babies up to 6 months old. However, there is support for mothers of babies for up to 12 months old for those who breastfeed exclusively for extra support, and babies and kids up to 5 years old. And so a review, or who is eligible for WIC, before we move on to the services provided by WIC. So it's for households earning up to 185% of the federal poverty line. Many people who qualify are actually unaware that they do qualify and are eligible, but those who are enrolled in Medicaid, SNAP, which is Supplemental Nutrition Assistance Program, or TANF, which is Temporary Assistance for Needy Families, they automatically qualify for WIC if they're in any of those programs. Also, immigration status does not matter for WIC eligibility. There is no social security number needed or other documentation of immigration status to get those WIC benefits. However, there is a very real fear of their information being shared with ICE for those who are eligible for WIC. So that is a barrier for some. So what WIC offers, actually quite a variety of services. So there's monthly monetary benefits to buy food such as fruits, vegetables, whole grain, iron-rich foods, milk, cheese, yogurt, formula, and more. WIC provides nutrition education as well for participants. There's education on breastfeeding and breastfeeding support, including providing breast pumps. There's also resource and referral navigation. The education includes quite a lot. So not only is there nutrition education, there is tips on shopping and preparing healthy food, and also how to get kids to eat it. I'm not a parent, but I understand that it's really hard to get children to try new foods. So I'm sure that's much appreciated. And now for WIC, there is a smartphone app to support shopping, which I think is pretty cool. So not only does WIC offer financial supports for nutrition and nutrition education, it also offers additional support for those who need it. This includes nutritionists, it includes breastfeeding specialists for education and support, breast pumps, and mother-to-mother peer support. And it provides referrals to other health professionals, including pediatricians, dentists, and vaccine services. So really a lot of wraparound support, getting folks connected with what they need, which is awesome. Next slide, please. So redeeming WIC benefits. Actually, sorry, can you go back? I just missed a whole piece of that. I apologize. So Eagle County WIC works in strong partnership with Community Health Services. So they're up there once a month providing services to residents of Pitkin County. They're also at the Elgibel Community Center in Eagle County once a week. And there's partnership with Aspen Valley Health as well in Valley View, providing a baby cafe. And the baby cafe is at the Elgibel office. Okay, now next slide. Thank you, Nancy. So not only does WIC serve families and individuals needing support, they're doing a lot of work in the community to make sure that those folks have a place to go to buy the food that they're eligible to buy. So WIC ensures that local establishments are accepting WIC benefits, and people in the Valley can go to a variety of grocery stores, including all the city markets, Walmart, and Roaring Fork Farmers Markets in the summer. So WIC actually provides additional vouchers to be used specifically at the farmers markets. And as far as the financial impact goes, so since 2023, the Aspen City Market has received $37,561 of WIC benefits. It's broken down by year. I'm not going to go through line by line, but you all can take a peek at that as well. And in total, in 2025, all Eagle and Pitkin County WIC clients enrolled spent over $800,000 of food on WIC benefits at local grocery stores, so almost $1 million last year alone. Okay, next slide, please. We love technology. So WIC is really important for public health. in addition to meeting people's immediate need to eat, it does so much more. So there's been extensive data and studies around WIC. And so some of the benefits that have been shown include improved birth outcomes. So pregnancies are longer with fewer preterm births. There is a lower incidence of moderately low and very low birth weights in infants, fewer infant deaths, and then a greater likelihood of pregnant women in the care receiving prenatal care, which we all know is important. There's also improved diet and diet-related outcomes. So higher micronutrient intakes of nutrients such as iron, vitamin C, various B vitamins, without increased total calories, so indicating just a more nutrient-dense diet overall. Similarly, we've seen increased nutrient intake without increased fat and cholesterol consumption. So again, another indicator that these diets are more nutrient-dense. There's been improvements in preschoolers' diets, so beyond that infant stage. And there's been a decline in anemia due to both WIC as well as other nutrition programs in the US. WIC has improved infant feeding practices. There's a higher rate of breastfeeding among those advised to breastfeed than those not advised to breastfeed. We've seen an increase over time of breastfeeding both in the hospital as well as 6 months postpartum. And then of those infants in WIC consuming formula exclusively, 90% of them are consuming iron-enriched formula, which is recommended for almost all infants. WIC has been associated with improved cognitive development in small children, so better vocabulary for children whose mothers participated when they were pregnant, and improved memory for numbers for children enrolled after their first year of life. We have seen improved preconceptual nutritional status and other other outcomes, such as an increased likelihood that children have a regular healthcare provider and improved growth rates in children. So I've put here the Colorado Foundational Public Health Services and Capabilities. You can see how WIC ties into a whole bunch of these. So there's the obvious, the maternal, child, adolescent, and family health, access to and linkage with care. We heard how WIC specialists refer staff out to other services as needed, dentists, pediatricians, etc. Prevention of chronic disease when people are having an improved diet. And we see partnerships, right? We're working with Eagle County to provide these services to Pitkin County residents. And also touches on health equity and the social determinants of health, getting people what they need to be healthy and live their best lives. Next slide, please.
Thanks, Ariel. So I think that was a really convincing argument for just how important the WIC program is. I get to talk a little bit about our partnership with Eagle to be able to ensure that this gets delivered to Pitkin County residents and how that works at the agreement level. So what this shows is the total expenses of the WIC program as it gets delivered by Eagle County. It's around $500 and something thousand a year to run this program. We do get WIC funding, but those grants only cover about 40% of the cost of actually delivering the services. So the county subsidy to be able to run this program is around, for 2025 to 2026, around 61%. You can see the total number of WIC clients between Eagle County and Pitkin County that get served in the program is 1,027 for this current year. The cost per WIC client is about $530. And only 35 of those clients are in Pitkin County. So it really makes sense for us to partner with Eagle County, who is running a great program with Fidelity, and that they're delivering this both in Algebel and also up here in Aspen. So you can see that overall, the cost for Pitkin residents is around $18,500, and our investment is around $11,300. So that is how we have the agreement with Eagle County to provide the services. That's how we financially support Eagle, and it's been a great partnership and relationship. Eagle County provides a fantastic service and is very responsive to any questions or data needs or things that we might want to bring up and work on together. Heath, anything you want to add?
Just wanted to celebrate the partnership as well. Quite honestly, I think the arrangement here goes back before I arrived as a public health director up here in Eagle County, but actually it dates back, I think, as far as 2017 when some of those WIC services were being provided to Pitkin County residents, even though that we only really formalized the agreement within the more recent past, over the past 2 to 3 years here. I think the WIC numbers in terms of Pitkin County residents has been pretty consistent over that time period. So maybe at the highest point, maybe around 50 clients, but you can see here in the past 2 years, you're looking at 35. The other thing I would just talk about in terms of where Jordana left off is we work with our finance team internally to ensure that we're providing the updated costs on an annual basis. And then that way, each year, that portion of funds that Pitkin County is providing to Eagle County for that service is based on those updated funds. And so it can fluctuate a little bit, and I'll give you an example of that. In the total expense projected line here, you can kind of see in the prior year that we have there, it was $500 and almost $95,000. That's come down a little bit with some staff changes here. We've had some longer term WIC health educators move on from their positions, move down to the front range, unfortunately for us. But as we've then brought in new personnel, they're paid at a lower rate. And so we're just making sure that we're as transparent as possible with what the cost is to run that program and provide the service. But right now, just a whole lot to celebrate in terms of how we're able to manage that relationship, and a huge amount of gratitude to Jordana, the rest of the team there in Pitkin County for keeping this partnership really strong.
Any questions from the room?
I have a question. Back on a previous slide, I think it was the amount of the cost at City Market Aspen, but it looked like through the years it had decreased quite a bit. And is that because there are less people taking advantage of this, or less people that maybe qualify for this up in Aspen, or do we know why that?
I agree.
Yeah, I can jump in with a little bit of an explanation. I think realistically over 23, 24, those numbers are fairly consistent. In 25, you'll see then that big jump. So for individuals that might be visiting our Algebel clinic, they may be visiting the City Market that is going to be located in Algebel. I don't know if that accounts for all of that, but I can tell you from our team's perspective, they did highlight that as one of the reasons for the anomaly there in 2025. And then obviously we're still super fresh in the 26. And so we'll see the number in 26 climb, but we can keep our eyes on any other trends that we're seeing as it relates to some of that. But I don't think it has anything else to do with it in terms of access otherwise. I think it's just individuals choosing to visit different markets to utilize those food benefits.
Okay.
I think the other piece would be the total number of Pitkin County residents who are enrolled in the WIC program. As Heath mentioned, it had been up around 50 for a while, and now we're kind of seeing it drop down to this 35 number. So that's also something for us to get curious about.
I suspect, just thinking out loud, that cost of living up here is driving people down Valley. And that I just looked up, I had to remember what the federal poverty level is. And did you say it was 160?
185%.
185. For one person, it's $15,000. So 185% is like, who can live in Aspen?
Live here. Yeah.
I mean, so that was my initial thought of why that was going down, but I'm sure it's multifactorial.
Yeah, and I just want to make sure that we're not, people are unaware of it, or, that we're not finding people as well as we used to or something. But it definitely makes sense that more people are down Valley than up here.
WIC, or women infants and children, is an essential public health service. And it's disappointing. I think that bears some, years ago, like 10 years ago, I was aware that Valley View had a nurse to encourage and train newborn mothers in nursing. Do they now, and what does Aspen Health do?
Yes, I can speak to that. I mean, just from my time at the hospital, the obstetric staff is trained to provide resources. There's a social worker that goes in to all rooms and explains benefits, and there's a pamphlet that each new patient gets.
There's a whole lactation service and support, and community health services provides WIC here, and they're closely tied in with prenatal care and capturing these patients and families that would qualify for WIC.
Now, Linda has been a midwife. Is the midwife population can do anything to encourage that, or what?
I don't deliver babies anymore, but I haven't for quite a while. But yeah, I'm sure the private office, usually the private offices don't have that population. It's usually community health services that has that population.
I mean, we do see that when
The
I worked at the
population that-
hospitals, we saw the population of Medicaid patients or people that were disenfranchised, underinsured, and anybody that hit certain demographics would be screened by social work or a mental health professional.
Right.
So.
Maybe I can add a few other pieces. I just want to confirm, there's a huge partnership with Community Health Services. And so the earlier that a pregnant mom is aware of what WIC can offer and then enrolls in the program, the larger the benefit, not only to the mom, but obviously then the child. And so I think there's always room for improvement in terms of communicating, but at least when we think about what information is provided to potential clients from Community Health Services or even Aspen Valley Hospital or Aspen Valley Health, and then Valley View, it's at least with this program, it has been around for such a long period of time. It is the one program that all providers, whether they're seeing the patient or not, are very familiar with. So as long as somebody is eligible, typically speaking, we will end up receiving those referrals and get them enrolled into the programming. And then I'll also offer, we have the lactation specialists that are coming from Aspen Valley Health and then Valley View that meet in the middle there in Algebel to offer that baby cafe. And so that has not only the benefits in terms of lactation support, also has the ability to then be provided in a preferred language, typically Spanish where necessary. And then the lifelong benefit for those individuals is that they're building these peer relationships with other moms that in that period of life. Oftentimes what we'll end up seeing is that those relationships will continue on even after their time utilizing Baby Cafe has ended. But I know there's been times that a number of those moms in the Baby Cafe have gone on to form their own walking groups and stay connected over time. So sort of a nice tangential benefit of that social connectedness that some of the moms and families get from some of the services.
Patients are more commonly Medicaid patients, correct? So if the babies being born in Aspen are more from the wealthy population and not necessarily, Medicaid or Hispanic population, is it because the proportion of the population here is gradually becoming wealthier and is not going directly to WIC services? I'm just looking for a reason.
Yeah, I don't know that there's more wealthy parents delivering versus less wealthy or Medicaid population. I mean, I don't know what the data is, but any person that's pregnant that is delivering a child, the hospital accepts Medicaid, Medicare. I'm not sure I understand the question.
I will highlight, at least relative to what I believe I heard, is national trends in terms of birth rates has declined over the past numerous years, and so we've seen that to be the case also throughout Colorado. I can't speak specifically to what that looks like within Pitkin County, but at least as a neighbor, I can say that we've kind of been maintaining for a little bit. So in Eagle County, that's been roughly about 500 births per year. But there's no doubt that significant changes in terms of the economic landscape in our rural resort communities has an impact in terms of how many families can live up here and what services may offer some support. But it's definitely harder and harder for a whole host of families to make ends meet up in our communities.
And I'll add to that. So I'm just looking it up right now. So in 2024, there were 105 babies born in Pitkin County. Don't have the data for 2025 or 2026 so far, but I don't imagine it's much different. And so 35 would be about a third of babies born. So there's, not many babies. Mm-hmm.
Maybe the mothers are going to El Chapelle more than for, lactation supplies. The city market. It's an area to explore.
Aspen has a very robust lactation service and a very supportive maternity program. So I don't think they're deferring to other cities for any or towns for any of those services. I just think we have a lower population.
Yeah, but that's right. Yeah, it is.
People are deciding to not have children.
Yeah.
Or can't live here.
Or can't live here.
Right.
Yeah.
It is related to income again. So I think most people having babies in Aspen make too much money to qualify for WIC, would be my guess.
Mm-hmm. Yeah. They're insured. Mm-hmm. Privately insured.
Any other questions or comments about WIC or questions for Heath?
Jordana, yeah, I'd love to ask regarding the money spent in the community. I saw that the markets. I'm assuming most of the money spent is on breastfeeding, lactation supplies, but it sounds like farm markets are being utilized. It says, and I was wondering if Lift Up is involved in this, or is there any sort of relationship with Lift Up and the farm to food pantry program they have, and the other services they're offering? Is there a nexus, synergy?
That's not something that I have an immediate answer on as it relates specifically to Lift Up. Generally speaking, I'll confirm this and send some information via Jordana, but I think the resources from a community market like Lift Up are going to be provided to every family. There's no doubt about that. And so families may access a lot of their food supplies there at those markets. That said, I just am not positive on whether the food benefits are accepted at those community food pantries or food markets as they would be at, say, like a grocery store. So I can circle back and just confirm, but I can at least let you know that any type of community service like Lift Up is going to be provided as part of the referral package to ensure that stabilization and support for the whole entire family, regardless of where they live and then regardless of what that community resource is.
Great. Well, thank you. So then back on that same slide, pardon me, sorry, you could. So it looks like, they've redeemed $800,000 of WIC benefits in the entire program. That's Eagle and Pitkin, correct? Okay. So I was just trying to figure out how to do the math on all this. So I think I'm getting to understand it now. Regarding Pitkin County's investment versus Pitkin County's 60% share, it's on the next slide. If we could run it forward, or maybe that one. I'm sorry, but maybe I missed something. I'm trying to understand our investment versus projected cost versus percent subsidy.
The county subsidy, so I guess if you look at the first two lines, so the total expenses for the entire WIC program, and then the WIC grants that are received, The grants only cover for 39% of the total cost of the program. So that means Pitkin
Right.
County is paying 61% of the program cost for Pitkin County residents utilizing it. Eagle County is paying 61% of the total cost of the program for the remaining almost 1,000 Eagle County residents who are using the program.
Okay, now, thank you for that. That's all I needed. Great. Heath, thank you for coming and joining us. Ariel, great job putting this forward. What else have we got?
All right, moving on. Thanks, Heath.
Thank you.
Okay, thank you, Heath.
Yeah, thanks.
Opioid Abatement Council. Up next, Karina and Raleigh.
All right, and they are both joining
Hi.
us remotely. Hi, Karina, we can hear you.
Awesome. Great. Thanks for having me. I am just going to start with a pretty broad overview of the Colorado opioid settlement structure. But first, I just want to introduce myself. My name is Karina Shore. I am the Region 5 Opioid Abatement Council Administrator. I do work for Eagle County, which is also the fiscal agent for the Region 5 Council. I'm happy to take questions along the way. If you have them, please feel free to raise your hand. Otherwise, I'll just kind of keep on talking. So the list of entities and dollar amounts that you see on the left and the pie chart to the right, these are all specific to Colorado. The entities there listed are all of the settling parties that are going to be paying opioid settlement funds to the state of Colorado over an 18-year period. The settlements are structured to provide funding for that entire period, although the funding available to each of these shares, it really varies year over year based on the settlement structures. So as you can see on the pie chart there, the regional government share is really the largest of the four, and that's the one that the Region 5 Opioid Abatement Council utilizes primarily. Majority of the funds do go to local government between the regions, which I have a map on the next slide. In that local government share, you can see that Colorado really wanted to make sure that there was a lot of local input and control over how these settlement funds were spent across the state. That being said, there is also a state share and an infrastructure share that are both controlled by a state level council of, I believe it's 13 individuals who serve on that, and they also oversee the regions. Most recently with these settlements, you probably saw that there was a big one last year from Purdue Pharma, which is the company run by the Sacklers. And we do continue to see more settlements coming in every so often. I believe there was just one this week announced from Albertsons. So between the changing amounts year over year and the different settlements that continue to roll in, the actual numbers are always a little bit of a moving target, but we do our best. Next slide, please.
Corinna, could you just take a minute maybe and bring us up to kind of that 30,000-foot view level of why we even needed to have our Attorney General putting forth opioid settlements in the first place, and then how, like, kind of the overarching goal of this program?
Sure. So, I'm sure as you all know, the opioid epidemic has been has really been raging across the country since really the mid 2000s is when a lot of the OxyContin addiction took place. The federal government, along with all of the individual states as parties, found all of the parties listed on that first slide liable in that epidemic. And through those national settlements, each of the states received their own share of that because they were party to those lawsuits. And all of the funding that comes to the states is really what the states have say over how they want to use it. And so in 2021, the Attorney General's office under Phil Weiser led this effort to develop the structure that I'm sort of speaking about here with the different shares and then the regional map that you see on this slide. All of those settling parties, along with the participating local governments, so counties and municipalities, all have signed on to that opioid MOU, and that's really that foundational guiding document for all of this. The MOU also created the regions that you see here, and in a few slides I go into a little bit of the purpose and the allowed areas of spending for the funds. Does that kind of give a good 30,000-foot view, Jordana?
That was great. Thank you.
Okay. So as you can see here, we are in Region 5, of course. We are also with Garfield, Summit, Lake, and Eagle counties, along with Pitkin, make up our region. Our total anticipated funds right now across that 18-year funding cycle is about $10 million. We do anticipate that is going to go up. A couple reasons for that is really just the Purdue settlement that I was speaking about earlier. But there was also a second settlement that everyone signed on to last year. We did get 100% participation on that. That was with some manufacturers of prescription opioids, and then as I mentioned, the Albertsons settlement. So overall, like we generally are seeing increased funding amounts year over year because of those new settlements, but eventually we are going to start to see a decline in our annual allocations from the regional share. Next slide. So just a couple of relevant state parties that I wanted to highlight. First of all is that state level council that I spoke about. 7 members appointed by the state and 6 appointed by local governments. They serve as an independent council with the Attorney General as a non-voting chair. They are responsible for oversight of our regional funds, as well as doing the prioritization of the state share and the infrastructure share, which is a regular award opportunity that all regions and participating local governments can apply for to access that additional piece of the pie for mostly capital projects is what that is really focused on. And then the Opioid Response Unit is a team under the Department of Law, Colorado Attorney General's office, who really handles just that administrative part of the funding, including the publicly available dashboard, which does a really good job at tracking exactly where all of Colorado's funds are going and what they're being spent on. Colorado has been recognized nationally for the transparency that they've committed to when it comes to these funds. Next slide. So this is a visualization of what we refer to as Exhibit E. As a part of that Colorado opioid MOU, all opioid settlement funds in the state have to be spent according to approved purposes. So when we talk about the programs in which we look at funding, when looking at our distributions for the next few years and saying, okay, like where do we feel like this is needed? These are really the categories that we're talking about. So you kind of have that full spectrum there, from prevention, harm reduction, treatment, and recovery, and then a couple of areas, other areas, including administration, some planning, research, etc. Next slide. So all regions are required to submit 2-year strategic plans to the Attorney General's office. We are currently in our second 2-year plan. So as far as the 18-year funding cycle, we are currently in year 4. For our first strategic plan, we contracted to run an anti-stigma education campaign, which you see is that first one under prevention, mobile harm reduction, services with High Rockies harm reduction, and a data dashboard with Omni as that final bullet there. And then new to this current strategic plan are the youth programming mini grants, which we awarded 6 awards for those across the region. And then the 2 treatment and recovery projects with A Way Out, which I'm sure some of you are familiar with them. They are based in the Roaring Fork Valley. They're a really amazing organization that provides treatment scholarships, case management, peer support, and sober-friendly pro-social events. And then Hard Beauty as well won a smaller award under that RFP to increase some peer support and acute response in Eagle and Garfield counties. Raleigh, I'd love to kind of give you the floor if there's anything specific on our current programs here that you want to highlight for Pitkin County.
Thanks, Karina. I think one thing to highlight is High Rockies harm reduction, and we see that very present in our Upper Valley. So they are up at Health and Human Services and then Brush Creek once a week. And I think those locations are one of their most successful locations. Other than that, I think you're doing good, Karina. You're touching all the right pieces.
Could I ask a question?
Of course.
I have met Maggie Selden, who runs harm reduction for the Western Slope. I don't see her name or harm reduction for the Western Slope in here, nor do I see the Jaywalker Lodge that's down in Carbondale.
So go ahead.
Muggsy Saldine is the founder and director of High Rockies harm reduction. And she's been able to expand her team, which has been super helpful for her to ensure she's reaching the whole entire region with her services. So I just met one of her new employees who will be kind of running at least our area for now. And they did also just receive a new van, which is just super helpful for winter driving and client capacity.
Thanks, Raleigh. Yeah, I apologize for abbreviating High Rockies harm reduction, but that is a contract with Muggsy Saldine's organization there with the mobile harm reduction services and the vans that Raleigh mentioned. We applied for infrastructure share funds last year and received those, so we've been able to utilize the infrastructure share for some of our programs as well.
And I don't think currently Jaywalker Lodge receives any funding from this particular organization funding source.
Yeah.
I just was clarifying that.
Yeah, no, thank you. Any other questions about sort of the current programs? And happy to take them at the end too if folks want to wait.
No questions in the room.
Great. Next slide, please. Just some additional expenses. Actually, you can go back one slide. Yeah, just some additional expenses here. I want to highlight that my role is also supported by the regional funds there under planning and coordination. We sponsor our council members to attend the annual Colorado Opioid Abatement Conference, and then there's some admin fees from Eagle County as that fiscal agent. Next slide. So as far as membership, the region is comprised of voting and non-voting members. For voting members, we designate one for every county, and they have to be filled. That role has to be filled from somebody within a participating local government. So that can be a public health or human services staff member, an elected official, law enforcement, etc. And they are really responsible for signing off on those big formal items that you as commissioners are all very familiar with. Final selection of funding recipients, amendments to strategic plans, We had we had a contract matter last year that the voting members were really involved in. So there really are the 5 voting members are our quorum of decision makers. County commissioners have that right of first refusal for the voting member role, so they get that first opportunity to fill that, but they can also delegate it to a county government or municipal government employee, which is what Pitkin has chosen to do. Currently, we have Jenny Constable as the voting member, and Jordana Sabella is our proxy. Next slide, please. We also have non-voting members on the council, and this eligibility is a lot broader. So in addition to more government representatives, we also can utilize healthcare system staff, behavioral health providers, school district, higher education, harm reduction experts, and really crucially, community members, especially those who have lived experience with the opioid crisis or substance use disorder. And this is really where we've been able to incorporate community voice into our funding prioritization and awardees, especially with members from the recovery community. So while these members don't formally do that sign off that the voting members do, we have a really great level of participation in some of our advisory committees and work groups from non-voting members. And they are really instrumental in helping us develop recommendations and overseeing ongoing work in a way that is aligned with the council's goals. Next slide, please. The full council only meets every 6 months, but as I mentioned, we do have some of those work groups and committees. The full council meetings are aligned with the Attorney General's funding request cycle. So we can request funds in March and September, and so we meet in February and August. All meetings are virtual. Everything is posted online. Our current posting page for the council is the same as our data dashboard. So that's where all of the public information, public notice is going to be found. And then the work groups and committees, those are more regular and ongoing. So executive committee is meeting monthly currently, and that's really to provide some administrative and strategic oversight of the council as a whole. We have a harm reduction work group that primarily meets with Muggsy Seldine every month to talk about expanding services across the region, supporting that organization, because they really are unique in our area and they do wonderful, wonderful things. Our anti-stigma and education campaign work group meets monthly as well, and they've been really great with that work group connecting the contractor, which is a group out of Denver, with local community members who tell their story about, either their own struggles with substance use and how they found recovery, or highlighting local resources and organizations that our members of the public might find useful for them or their loved ones. And then we have a data and evaluation work group, which is currently exploring some next steps. We had the data dashboard finalized at the end of September of last year, I think. And so that's now public. There's a Spanish language version as well. And it's just a really great place, I think, to find a lot of interesting data around the opioid crisis. We track some of our own project outcomes on there, but then also pull a lot of secondary data sources to characterize what the opioid crisis and substance use looks like in our region. And next slide, that's really all I have for today. My contact information there, and the AG Opioid Response Unit contact as well. They're really, really helpful, not just for the regions, but for local governments as well, who I believe Pitkin County does receive their own share of the opioid funds.
Thank you, Karina. Appreciate it. Nice to see you online in person.
Yeah, it's great.
Any questions in the house?
I don't see any.
Okay, I can just barely hear you again, Jordana, but I think I heard that. Okay, I think we're done, wrapped up. Thank you very much. On to the next event.
Thanks, Corinna.
Healthy Community Fund. Oh, she's still here, maybe gone. Healthy Community Fund update.
Great. So
Pull
if we
your
go,
mic up close, will you?
how's that?
That's better. Thank you.
So if we go to the next slide, I think probably most folks in the room are familiar with the Healthy Community Fund, but I'll just do a really brief history. So this fund came into existence in 2002. When it was first put on the ballot to establish a new property tax. It was really, the goal there was to use for emergency needs and requests for health and human services organizations. That passed. It was originally just a 5-year tax. 9 organizations were funded from that. It has subsequently been put back on the ballot and passed an additional 3 more times. And the current iteration has included an additional $750,000 to be able to seed the funding of the public health department. That was back when 2017, the public health department came within the county. And this funding source was helps sustain the public health department funding as well, which we can see on the next slide. The amount of revenue that the Healthy Community Fund brings in. These are just the funding amounts after every renewal. The following year, the amount of revenue that was brought in. So you can just get a snapshot of seeing over time how in 2003, it started off bringing in just under $1 million. And now the revenues are in excess of $3 million. So this is a really important fund, not just for the public health department, it funds senior services. It also funds a number of community not-for-profits, as well as behavioral health work that we do, integrated care work in the community, and a number of other contracts to provide these critical core health and human services in the community health services. If we go to the next slide, what I wanted to be able to discuss today was this process. So the Board of County Commissioners decided to put the renewal of the Healthy Community Fund on the ballot in November of 2026. I have that number wrong. So it's this year. We are in 2026, and it will be November of 2026. They just decided that during their retreat last month. So what this means for the process is that staff work with the Board of County Commissioners to help finalize the ballot language of what will be put out to voters. Once that goes to get put on the ballot, staff are not able to spend any more time working on that initiative. We can provide information if there are requests for information or answer questions from the community, but there's a really clear delineation between staff duties of just operationalizing that and getting it on the ballot. And then after that, it gets turned over to community members, council people, elected officials to be able to do any kind of community education or bringing forth that initiative and showing support for it, garnering support. So that process, we expect to have that get sent to the clerk's office around August. And then after that, it will be in the hands of the community to put this forward. So I know Ted is here to talk a little bit about his interest in helping with some of this work. Greg, I know you would like to talk a little bit about it, but I just wanted to make some time on the agenda today for board members who I think many of you probably have been familiar and involved with ballot initiatives and what it takes to be on that community side of it. And for those who might not have that experience, to just hear what a process like that kind of includes, and then if you would be interested, understanding what kinds of different roles will be out there and available for you. So, Greg, I'll turn it over to you.
Great, thank you. Thanks, Jordana. So this is exciting and it's a little daunting. I've been involved in the ballot measure. One that pops into my mind first is just wrap this, 2040 update. But peripherally, I wasn't managing it or running it. So we're going to be looking to the people in the community who really want to help, either as advisors or mentors, I'm going to say. Ted has some experience, and I'll let him, if he's still there, I'll let him describe it. But I think what I heard from Patty Clapper is that she's done. She's finished in January and doesn't want anything to do with it. Francie Jacober said the same. Jeffrey is our chair this year, and he's quite busy. And so I think it's, Ted and I looked at each other and we both said, yes, let's do this. And I'm actually quite enthusiastic about it, and I'm very confident. But the only way it's going to work is if we have people to at least advise, if not jump in there with us. So I'll leave it at that. And I'd love to hear the interest, and you can either communicate with Ted or me individually, or after you think about it, after you sleep on it, or let us know what you think now. But we have to mount a campaign, and we have resources to help us. We've got a lot of smart people who believe in this. So I think that it's going to be a winning campaign. I have no concerns about anything but success. But I'm also looking for the team who's going to help us do it. And I'll leave it at that. And Ted, if you want to jump in and talk about your experience, that might be helpful.
Yeah, sure. Thanks, Greg. And I don't think it's right to frame this as drawing the short straw with other busy BOCC. I think that Greg and I both love the topic. I think we all value the role that this plays in the community. I didn't come here prepared to present how we go about this, but I am able to refer to what I have done in the past with the single ballot initiative I helped. So I wouldn't call myself an expert consultant, but I do have experience, and it was local. There's a few things that are really in our favor right now. Like Greg said, this is a really popular program. People like it. It has a broad reach. It touches a lot of organizations, which in turn touch a lot of people. So to leverage that network is not hard to see how it would be easy to campaign and get the word out, because this isn't, while this is an initiative, it's really a messaging campaign. We have to share the word, get some enthusiasm. There aren't squirm nights or interviews. It's more getting everyone in the community to realize the value of this program and coming up with the message as to why it should be renewed. So it's April. We have a lot of time ahead of us, but not an infinite amount. So I think that Jordana's probably been thinking about the timeline on some of this. I think the first thing that has to be realized is what do we want to have on the ballot? So there's a lot of choices here. We've seen the revenue this generates, and we can see what projections would look like ahead, and we have to decide, is that what we like? Is this adequate to stay the course, or do we want to make changes there to adjust? Do we want to change the structure of the funding so maybe there are more funds coming? What does the future of the program look like? And this is something that, we all have to discuss. This is would be the fifth time it would be passed. So for example, it's always had a sunset on it. It started out, I think, at 4 years, and then it went to maybe 6. The recent one, I think, is 9 years. So, we could consider a lot of ways to tinker with this. We could, of course, just keep it the same, but we could also say remove the sunset. Do we want to always have to stress about it being renewed? Do we want to keep the sunset and maybe change the terms of the fundraising right now? Maybe Jordana, can you remind how it's set up, where the funds come from? It's not a property tax mill levy. It's It's set to a fixed dollar amount, if I
It's a
recall?
fixed mill.
Fixed mill, okay,
It's a fixed amount, not a fixed mill
okay.
currently.
So, well, when we had our retreat and we were discussing if we want to move forward on this, there was a discussion if we wanted to change that because there are other programs in the county, particularly open space, that has ended up generating even more revenue as property values have gone up so much. So this is a consideration too. And I guess so. The point is, we need to decide: do we want to just stay the course? So we need to discuss, what the future of the program looks like, what kind of funding is needed, and of course that doesn't happen in a vacuum. We're dealing with federal cuts and state budget deficits, and so we are now increasingly becoming the backstop for all of the funding gaps that exist, city and the county. So we need to come up with that first, right? And I don't know if that, what the timeline would look like for discussing that. And then I believe that has to be presented to VOCC, and we would agree or tinker and then approve ballot language. At that point, or concurrently, you want to start organizing a committee to help push this campaign forward. And that would be helpful to probably have legal advice on what can and can't be done. As far as what we did in the city, we were able to have some of the members of the City Open Space Board be on that committee. We are allowed to do that. You just can't speak as a member of the board. There's just some fine print, which shouldn't be a surprise, but it was put together by several other people, members of the community, and 3 or 4 of us that were on the city board. So that would be an option for us here. And it would be an option for Greg or I to also be involved. And then we'd probably want to come up with some interested, community partners in this program who would also be good voices for this committee. And then it's a shared effort. You're not running an individual campaign. It's a team. And so everyone can kind of divide and conquer on what those tasks would be. So, I don't think it has to even incur lots of I don't know if there's questions on this at this point as far as personal experience, but the campaigns were pretty simple. And the one that I'm referring to, it was letters to the editor. It was a couple of op-eds. I penned one, even as a member of the board, and then Jim Truitt said at the time that was completely fair to do. There was a lawn sign campaign, and postcards were mailed out, and I created the graphics of the postcard at home on my laptop. And, so there's not a lot of costs into any of that except the printing. We did have some funds raised that was not my department on the committee, so I'd need to check with the person who did that. But some, nominal money was raised by interested community members that paid for that printing. And then we were able to go to the office here and get a list of voter rolls of, send the mailers to those who we thought was appropriate. In the end, we decided to not change the funding. It was a 0.5-cent sales tax. We did remove the sunset. And the thought on that was the tax was passed in 2000 for 25 years. We actually got ahead of it by 3 years, so we weren't running against the clock to renew it in 2022. And we said, let's keep it at the same funding, but we'll get rid of the sunset. The program has been proven successful. Community really supports it. Sunsets are good if it's a new program and people aren't sure if this is really going to work out, so something to consider there. We were kind of conservative. We said, let's keep it at the 0.5-cent, remove the sunset, hope it goes well. It was supported by 73% of city. So you could say we didn't ask for enough. In hindsight, I think we didn't need to tax more, but there's a concern right now. And where do we want to go in that decision? Sales tax enhancement, I believe, just crossed 10%. Everyone likes to support all the programs here, and this one's probably no exception. But at a certain point, people are going to say no. Enough is, that's enough. So, I'm kind of bouncing around here on the topic, but that's something to consider. I don't think I was just took some notes down as we went down. I honestly, I would like to look at it as though it's not that complicated when you have a committee of 8 or 10 people and everyone divides the tasks on where they are, and we can lean on the network that we already have. Yeah, I agree with Greg. It's a popular thing, and we should be able to push this through. We just have to have some conversations about what it looks like.
Thanks for sharing.
Great. Thanks, Ted. Jordana, do you want to add next steps? I could offer a little bit of commentary on what Ted said, and I agree fully, and that was really thorough. Thank you. Um, Questions that would come up would be, do we want to sunset it? Do we want to eliminate the sunset? Other questions would be, do we want to be more inclusive of nonprofits that have been kept out of Healthy Communities Fund? Another question would be, let's see, we had sunset, we had inclusive, the amount, I guess the amount we're trying to raise. What percentage are we throwing out there? Are we going to change that number? I think that one facet that I think would be very powerful would be to get the testimonials from the people who've been touched by the program for a campaign, so that people could see what their friends are saying about how valuable Healthy Community Fund is. It's proven very effective in the papers for our election campaigns when you have the names of all the people in the community to support whatever it is you're trying to do. And I think we could build that list, and it would be a really impressive list as we go forward. And so that might require some advertising dollars to place those ads, but I also think we could raise that money and it would be worth it. So a lot to think about, but it's also really exciting. Like, what else were you going to do this year? Jordana, can you talk about what next steps that you see and any deadlines you see?
So, the next steps, we're going to the BOCC to hopefully get some answers to those questions around sunset and fixed income versus fixed mill. In a couple weeks. So we'll be coming back. The BOCC is the one who gets to make those decisions. And then after that, or as Ted said, concurrently, any of the organization that wants to happen for support of the ballot initiative can't involve staff. So I just wanted to have this be a forum where you as citizens or Board of Health members are able to participate in a way that staff currently aren't.
Thanks for that. I did want to say, the Pitkin County Commissioners are the deciders, they're the policymakers. But I think we depend upon your input. I think we want to hear from the Board of Health members, individuals, or working without staff, on how they think this could proceed and what's needed. We can have a robust conversation at the BSCC level and miss a lot of the nuance that you all are working with as health professionals and people in the medical and health community. So I really would encourage people to weigh in with their thoughts on this. And I guess it can't go through Jordana, it can't go through staff, but it certainly is important, because when it comes to us, who knows where the conversation will go, and it will depend upon the quality of the information we have. Thanks.
I think, I'm sorry.
Go ahead.
Well, I think that it would be good information, and probably we'll need to get it from staff, about what increased costs we've had because of federal cuts, basically, and what we anticipate even in the future, because that's a pretty strong message when you're looking at how much you're asking for and why. I think that's really important.
There's a way to free up some Healthy Community Fund monies, because I've been involved with the senior center, and the senior center gets about $500,000 from the Healthy Community Fund, but it's not a 501c3. So let Pitkin County directly fund the senior center, its whole budget. That would free up money for the Healthy Community Fund. There were, I think, a couple of other government agencies like that were direct funding rather than the government agency getting money from the Healthy Community Fund.
I think Greg could probably talk to that better. I do think that there are continued beliefs that the county has in the general fund funds to support all the programs everywhere. And so the requests are coming in from all directions.
It might help.
It could help, and it's in one option, and that's why I'm saying Greg might have a better role. I'm adjusting to my job, but it's been about 5 weeks, so I don't have all the answers. Greg?
Well, I was just going to say, yeah, somebody always has a suggestion. Well, why doesn't Pitkin County just pay for it? And we hear that up and down the valley. We do have a general fund, and we do distribute money from the general fund. We have a lot of budget supplementals every year. We actually are concerned about our general fund and our available money. We're obligated to keep certain levels in there just so we have operating capital to last for months. And so we're not as flush, and we don't have extra money to throw around. I can say that. So the Healthy Community Fund is necessary, and I don't think we can just eliminate them and taking it from them and paying it out of the general fund. But you do make some good points, Dr. Kurt. There's some interesting spillover worth examining. But it's a worthwhile conversation, but I don't think we can just say, oh, we'll find the money elsewhere. I think we're going to need to either expand the general or expand the Healthy Community Fund or perhaps propose new rules for it.
Krista? I'm sorry. It's hard to find the right button sometimes to push to come off mute. Michelle?
Just from a mental health perspective, it does feel like the fund is a little diluted, like there is a duplication of a fair amount of services where funding is going. And I understand why, but I also wonder if it would be worthwhile to be more stringent around qualification, rather than like little bits of money going to multiple organizations that do the same thing versus like a lump sum that can really get your biggest bang for your buck. Just, tightening up the qualifications and the guidelines. And, when you see how much the fund has grown, like I think it's like 76 organizations or something versus 9 when it originally started. And that's not to say that these organizations aren't great organizations, but, are they really all supporting the goals of the Healthy Community Fund?
Yeah, I wanted to echo your comments, Michelle and Susan, as far as just like when you talk about taxation, you got to do it responsibly, and you don't want to ask for more than what you need. So between tightening up potentially the parameters of this program and only asking for the amount that you're going to use in the quote unquote responsible way, I think anyone would support this. That's why I think it's like the due diligence that needs to be done to find out how much is truly needed and making sure you're not just doing a mill levy and asking for too much and then potentially getting voter rejection, especially after all the taxation that's gone in place in this community of recent memory, because it will hit people's bottom line elsewhere too. So, but it's very reasonable, this fund, but it needs to be reasonable to ask to make sure you're asking for the right amount.
And also, like, yeah, I would be happy to participate or lend some time or knowledge, just because when you look at the list and you see, like, some of my questions were like, why is so much money going to this organization? They haven't proven to me in my work that they're doing enough, and why does this other organization that does so much getting so less? It just seems very disparate. It doesn't. Yeah,
I agree with you.
Yeah, I agree. I don't know what the parameters are, and that would be good to have more clarification on what are the parameters.
I can share that the Healthy Community Fund does have a committee that spends, I'm going to say, agonizing hours going through all the applications and trying to figure out how to fairly distribute the money. The committee is our citizens from the community, and I know they take their work very seriously. Everyone has favorites, there's no question. And it gets can get a little bit more squishy when it comes back to the commissioners, and then we change the numbers based on our own biases. So yes, it's a complicated ball of yarn. I'll call it that. It's also really worthwhile, and there. But I definitely take your point. You really want to have the money spent the best way possible to do the best job with the group that's going to get the work done. And I think that's the question we ask every year. And it's too complicated for us all to understand it completely. I can share that as well. So at first glance, you do wonder a lot of things like that. And I think as you get into the details, maybe sets of fresh eyes on it would be helpful. A recommendation from the Board of Health that we scrutinize it isn't a bad recommendation at all. Restructuring the Healthy Community Fund may be a pretty difficult thing to do if it really needs restructuring. I'm not sure it does, but that's a question that's merits an answer. So I, those are all really great questions, but I also know how hard the group works to try to distribute the money fairly, based on need, based on ability, based on service. There are a lot of factors that go into it, and so it might be necessary to do more informational sessions just so we all understand how the fund works.
And that's just a portion of it. That's just
a portion. That's the health portion you're talking about, right?
The city of Aspen County and the state are losing tens of millions of dollars of sales tax in Aspen. If you look at the Crystal Palace, which has not really functioned since 2009 when Metcalf sold it, there were millions of dollars of sales tax from Meade Metcalf's diners, 2 shifts of 200 people per night. And the city of San Francisco has what's called a disuse tax. If a property is not in active construction or used for 180 days or half a year, they pay a disuse tax, and that is stood up. So we have about at least 10 properties around here where the city, the state, and the county could be making disuse tax.
Right. That's a different, that's going to be a different ballot measure, I think, or a different proposal. And yeah, you make good points there. It's terrible to see disused buildings, especially that one. That one hurts a lot. I think it'll be easy to get off track. I'm not sure what else we need to discuss today. I'm not expecting people to sign up immediately, but if you want to, certainly we'd appreciate it. But I'd encourage you to talk to Ted or me, and we can work on getting the body of information together so we can start figuring out how to attack this. What else do I have to do for you today on that topic, Jordana?
That's it for that topic. And then we've just got round robin left on the agenda.
Right, for round robin, thank you all. Ted, this is my favorite part of the show. And only where people can put out the big ideas or things that have come across the transom that might be relevant to the health or for the community to get. If I could, I'm going to start. I went to City Market Pharmacy the other day, and pre-COVID, I'd had a booster where I had the very first shot of the what is it after chickenpox? My God, what is that thing called? Shingles. Thank you. I had the first of the shingles boosters, and then somehow when I went back in within 6 or 8 months, COVID had started. They'd lost my data. They had no idea the shot was given to me, and so I forgot about it. And years later, a couple days ago, I walked in and said, "Hey, I never got the second shot. What do I need to do?" And the new information they shared, which was brand new to me, was the first shot's all you need. Don't worry about it. You don't have to worry about getting it done within a certain period of time. Just come back in when it's convenient. And I just thought there's new information about the shingles shot for people of a certain age, and I don't quite understand it, but it might be something a public health department would disseminate. Sorry, I garbled that. I'm not being a medical person.
We can look into that, Greg.
Yeah, and it's not just for me. I'm not asking you to do me a personal favor. It's just what they said is the policy seems to have changed when they noticed so many people did not get a second booster, and maybe it didn't matter. Maybe I don't need the second one, or we don't, those who didn't get it, the second one. Might be relevant. That's all I have for you. And I can't see hands up if anyone has anything else to share.
Anything else for round robin? Nothing in the room.
Nothing in the room, boy. Okay, our next meeting is July 16th. I appreciate y'all being here, and once again, I apologize for the clunkiness of me not being there. It usually runs a little bit more smoothly, but thank you, Jordana, for picking it all up and everyone for making it happen. I need a motion to adjourn.
So moved.
I'll second.
And I'll get a vote on that. All in favor?
Aye.
All right. Thank you all. I appreciate it. And we will see you all soon.
Thanks, Greg.
Thank you. Great job
Bye-bye.
remotely.
Have fun.
Thanks. Yeah, will do. Bye.